Hello, my name is Sigal Yavets, and I'm a member of the Division of Infectious Diseases at the Brigham and Women's Hospital. Today, we'll be speaking about current strategies and common questions in the management of urinary tract infections in the hospital. The talk is case-based. I know it's recorded, but I do have questions for you, so we'll just take a moment pause when I ask the question so you can think about the answers, although we won't be answering them live. These are my disclosures. I have no conflicts that are commercial, although I'm a member of guideline panels and write about UTIs and edit at Dynamed. The objectives of this talk will be to start with just general principles in diagnosis and management of urinary tract infections. We'll talk about syndrome definitions because they're evolving these days, when and whom to test and what tests to order, and then how to pick an empiric therapy versus test-guided treatment choice. And then we'll talk about some challenges you must be facing when you manage urinary tract infection in the hospital, including resistance, allergies, complicated UTI and bacteremia, how to transition from in to outpatient, UTI in men and prostatitis, UTI related to catheter, asymptomatic bacteriuria, and at the very end, I'll say a word on imaging and when are consultation needed for UTI syndromes. We're going to start with a simple case, and things will get complicated, I promise. This case is just to illustrate how we work with diagnostics. So this is a 47-year-old female. She has a BMI of 34. She has prediabetes. Her A1C is 6.1. She's not pregnant. She has no other significant medical history. If you haven't asked a patient these questions, these are some pieces of information you would want to get when you evaluate someone. No medications, admitted with pulmonary embolus following a 13-hour flight. On review of systems, she reports a 3-day history of dysuria and urinary urgency. She basically says, I think I have a UTI. And she had prior similar episodes about once a year, so this is not her first UTI. She has no fever, nausea, vomiting, or flank pain, no recent hospitalization or antibiotics, except the malaria prophylaxis she took for the trip that gave her the PE. So the question we ask ourselves is, what is this syndrome? And that the definition will help us decide what our strategy will be as far as diagnostics and treatment. So I would call this simple cystitis, what was previously known as uncomplicated UTI, it still is for registration studies. And it's a classic lower tract infection that involves the bladder only, causes dysuria, urgency, and frequency, and there is no upper tract symptoms or constitutional symptoms, fever, systemic toxicity. Simple cystitis without fever. So the UTI definitions are kind of evolving when we come to decide what to do with patients. There are traditional definitions. They are the definitions also that the FDA would use for registrational studies of drugs to treat UTI. And they divide UTI into uncomplicated UTI, which is acute cystitis in a healthy, non-pregnant, young, which is basically premenopausal woman, without diabetes or urologic abnormalities, or presumed at least. Then there is acute pyelonephritis that is not complicated, and then there is complicated UTI, which is everything else. So this is what we all learned in med school and is still in some of the textbooks. When we talk about evolving definitions, these are definitions that are more clinically oriented. And in the area of resistance, as you will see, may be more relevant to most of us as clinicians. Currently, the up-to-date chapters already adopted these definitions, and European guidelines and US guidelines will likely adopt some form of these definitions. So in the new definitions, we talk about simple bladder infections as uncomplicated, and that is simple cystitis in men and women where there is no fever, very much like the patient we have, and then complicated UTI is everything else. And the reason why is everything else is what we treat a little differently than someone with just simple cystitis. And that includes all pyelonephritis, prostatitis, fever, or systemic toxicity, bacteremia, sepsis, or shock, obstruction, and anything else you think makes it more complicated than just simple bladder infection. So we will work with these definitions today to talk about how you would manage UTI in the hospital. So this woman we've already determined, she's 47-year-old female with simple cystitis. So this is a survey question. There is no one correct answer. And the question to you is, what would you do? One option is, hey, she's here for PE. The UTI symptoms will go away. Let's just ignore it. Probably not a great idea. But as an outpatient, we'll talk about what that might mean. The other option is, this is simple cystitis. It's outpatient acquired. This is not a hospital-associated cystitis. She came with it. Let's just give her empiric antibiotic therapy and see if she responds or not. In the outpatient setting, that would be a reasonable approach. In the inpatient setting, you have the tests available, so you might choose to do testing. Then there is the option of test and treat empirically while awaiting cultures. And then there is the option of test and wait for cultures to treat. So think what you might do when you have a patient like that in the hospital. You're treating her for something else, and she comes in with UTI. Very, very common. So let's talk about the options. So option one is more for instruction. And the question is, what happens to simple cystitis if we just ignore it and do nothing? Or what's the natural history of simple cystitis in a young woman that we assume has a normal GU tract? And we actually know that from data, because nowadays we obviously do studies. We have placebo-controlled studies that compare to standard of care. But in the past, studies for UTI for simple cystitis included a placebo arm. So we know what happens in a placebo arm. And I gave you on the right here just a table of one such study that compared nitrofurantoin to placebo, so we can see what happened to the placebo arm. In this study, symptomatic cure or improvement on day 3 was in 44% in placebo arm, and on day 7, 54%. So when we talk about, and there's several other studies, episodes of UTI in young women that have no complicated tract, they can resolve clinically by 2 to 4 weeks in 40 to 50%. And we have to remember that we then compare 2 studies of a medication, that no response is not our baseline, because some women will just resolve their UTI, and it's kind of a spectrum. Women can flush out bacteria, and with hydration, symptoms will get better. So a drug that performs at 40 to 50% may be no better than placebo, even though we don't have a placebo arm for simple cystitis. The majority, up to 70%, will also clear the bacteriuria. So that's the microbiologic cure we look at, not the symptomatic cure. And that's also in this table as bacteriological cure. It was 41% on day 7 in the study. And progression to pyelonephritis or renal failure is rare if there is a normal GU tract. So you're probably not going to harm the patients, except they'll be miserable and they wouldn't appreciate you if you don't treat them. So then there comes the question of testing. And this is more of a question for the outpatient clinician than the inpatient clinician. But there are some pros and cons that we should discuss. Or you may want to still know what's going on in the outpatient setting if this is a patient who's in the hospital for a day, and you may want to send her out. So you may not want to have too many tests pending when she leaves the hospital. So testing for simple cystitis in women, the pros are, if you test, you get diagnostic accuracy, because the sensitivity of only one symptom is about 50%. And one symptom is one of dysuria, frequency, or urgency. Dysuria alone probably has higher sensitivity. Of course, a negative urinalysis, we'll talk about that, can exclude a significant clinical cystitis. We know there is resistance, so we can choose antibiotic, and there's obviously stewardship that we preach, societal and environmental and personal costs of antibiotic overuse. The flip side of that is someone who complains about all 3 symptoms The sensitivity of this is about 96%. So why do we need a test if we know exactly what we've got? The causative organisms in young women are predictable. I'll show you all that data. Most women respond clinically to a standard empiric antibiotic, whether they're resistant or not. And cost of visit and test if they are outpatient. So there are several phone triage studies that show that it is cost effective to just give empiric therapy, and only if someone does not respond to get testing, unless they have a high risk of resistance or not responding to therapy. So what tests can we do to prove we have a urinary tract infection? So one is to look for inflammation in the bladder, and the correlate to that is pyuria, the presence of white cells. The test for pyuria is very sensitive, but not specific. So pyuria means more than 10 white cells in midstream urine. That's if you just dipstick it and don't spin it, or more than 5 in spun urine on a sediment. And then it's present in almost all acute cystitis. The sensitivity is really high, with the exception of a patient who has no white cells, neutropenic or obstruction, above the bladder or below the bladder. But on the other side of this, pyuria is very common even without cystitis. Any pelvic inflammation or infection recent period can result in pyuria as well, and kidney disease, some kidney diseases. So specificity is low. You can have pyuria and not have a UTI at all. And the dipstick look esterase basically is just a correlate of pyuria if you do dipstick and not a sediment, and it's meant to count those 10 white cells. What about nitrates? So nitrates are looking to see if there is bacteria in the urine. It doesn't mean someone has cystitis. They can just have colonization or even urethral colonization. It just says there are bacteria. There is bacteria. It can be asymptomatic bacteriuria. The sensitivity is quite poor. Why would we have false negative? It's sometimes because the counts of bacteria are relatively low. Women drink, or anyone, when we are UTI, we recommend to take a lot of fluid so you can dilute the urine. You can look at the concentration to see if the urine is dilute. And there are a lot of bacteria that do cause UTI but don't produce nitrates. Enterococci are an example, Staph, Acinetobacter, etc. But the specificity is very high, because if you have nitrates, 99% of the time or 95% of the time, bacteria made the nitrates. So the nitrates mean bacteriuria. It doesn't necessarily mean that it's cystitis. It just says there are bacteria there without having the culture. So what are actually the positive and negative predictive values for an eventual positive culture if you use a urinalysis or a sediment? So this study looked at patients divided by age groups and looked at the sensitivity or specificity, positive and negative predictive values for a positive culture with more than 100,000 of a uropathogen. And it looked at the look esterase at all ages, nitrates, bacteriuria, and white blood cells. As you can see here in the second to last column, the positive predictive value for UTI is terrible. It gets as high as 54% in greater than 70 years old, and for all it's 11.7%. However, the negative predictive value of white blood cells in the urine is extremely high, and it's in the 90s. For all comers, it's 99.2%, and a slightly lower percentage rate for the oldest of patients, and that's because we all know that bacteriuria is much more common with or without UTI in the elderly. So this is to say the positive predictive value of a UA is very poor. UA is not enough to make a diagnosis of UTI, but the negative predictive value is excellent, which means that if you have a negative UA, unless someone has obstruction or neutropenia, you do not need to do a culture. That person is unlikely having a clinical urinary tract infection. And this is why many institutions, including ours, have moved to, you can't order a urine culture unless you explain why. You have to do a urine analysis, reflex to sediment, reflex to culture, and then only positive UAs and sediments will go to culture. So why would we want to culture? Well, of course, we want to confirm the diagnosis. We all learned that more than 100,000 colony-forming unit of an organism, especially a uropathogen, is diagnostic of UTI with the right set of symptoms. It identifies what causes the UTI, and you can do susceptibility testing to tailor therapy accordingly. For urine, we don't use much of the PCR resistance testing. So it helps you find the narrowest agent and assure that the patient has no resistance and is going to respond to therapy. So now I'm going to ask you another question. So here are to the left a McConkey plate here. This is non-fermenter. Once there is a fermenter gram-negative rod, it will turn this beige to pink. And this is a blood agar. And these are more than 100,000 organisms of the same organism. So what percent of young women with simple cystitis, classic, dysuria frequency, urgency, have more than 10 to the fifth or 100,000 colony-forming units of a single uropathogen in the urine? So I'm going to go through in your head, is it 85%, 65%, 50%, 33%, and 25%? And the answer is 50%, which goes against everything we've learned, 50-50. So why do we even make that criteria of 100,000 colony-forming units? And what about the other 50%? Do they have cystitis or not? So most of the other 50%, the one who don't make it quite to 100,000, still have a uropathogen, but it's less than 100,000. And we call it acute urethral syndrome, although it's probably cystitis, early cystitis. And if we delay therapy and check them again in a day or two, unless they cleared it, they'll have more than 10 to the fifth. So many different studies, I put the two major references in the bottom for you, have shown that if you do have a uropathogen, and that means mostly a typical gram-negative rod, so that would include E. coli, Proteus, Klebsiella, etc., or maybe a Pseudomonas. In a young woman, that's predictive of cystitis. If you catheterize them, there will be bacteria in the bladder. And the majority just are early complainers or early symptomatic patients. And a small minority does not have cystitis, but has symptomatic abacteriuria, something else, whether it's urethritis, some unusual organism, chlamydia, mycoplasma, trick, genital herpes, or non-infectious process. The other thing about premenopausal women, and that's why we used to call any UTI in premenopausal women simple cystitis or uncomplicated cystitis, is that we can really guess the organism. They're predictable. And as you age and after menopause, here in this particular study, at age greater than by Kal Gupta, at age greater than 50%, you see a much larger diversity of organisms. So the old definition focused on, this is a young woman with a classic UTI, no likelihood of complication. And we kind of know most of them will have E. coli and a few will have Klebs and Proteus, and the rest are pretty rare. And once you're over 50, there is a much larger diversity of organisms. So old guidelines from 2010 from the IDSA and the international societies recommended to use empiric therapy for simple cystitis in young women under 50 with nitrofurantoin for 5 days, trimethoprim sulfa for 3 days, fosfomycin 3 grams for 1 day, or pivemicilinum, which we are not used to use in the US, although it's just FDA approved recently, so we could prescribe it, and did not recommend fluoroquinolones for 3 days or beta-lactams, mostly because of antibiotic stewardship, not because fluoroquinolones would not work. They would work very well. What happened since those guidelines, and what are we working on in the new guidelines? Well, these days resistance is much higher. You see here, the recommendation is to not give trimethoprim sulfa if your community E. coli resistant rate is less, unless your community resistance rate is less than 20%. There is no community in the US where it's less than 20%. So should we not use trimethoprim sulfa? Efficacy in some recent studies is lower. I'll show you one of them. And remember that nitrofurantoin or fosfomycin are not recommended for pyelo or anything but cystitis. I'll talk about some exceptions. So while you could use this empirically, remember that patients may be resistant. They might still respond because of the high MICs in urine. And when diagnosis is in question or when resistance is a concern, you should base your treatment based on culture, but you can start with empiric therapy. And I'll talk to you about how to choose that. This is to show you that antibiotic resistance, this is between 2003 and 2012 in community-acquired outpatient UTI. And you can see, and that is true to today, although the numbers may be a little bit different, that nitrofurantoin susceptibility in women who have not been exposed to a lot of it remains very low, but Cipro and trimethoprim sulfa resistance is on the rise. And these are comparing 2003 and 2012 by age. The age did not come up on this. And this is what I already referred to, the rates of resistance by locale. This is 2017. And you can see that resistance in the community for trimethoprim sulfa is anywhere between 33%, where I practice in New England, East North Central 26%, but as high as 43% in the Mid-Atlantic area. And nowhere is it 20%. So if you have no culture, you cannot assume that E. coli will be susceptible to trimethoprim sulfa. This is a study of the JAMA that many of you may remember. And this compared fosfomycin 3 gram to nitrofurantoin, 100 milligrams 3 times a day, not twice a day as we use it. And it looked at simple UTI, and the study has some weaknesses. Only 93% completed the trial, and only 73% has baseline culture. And resistance to both agents was low for E. coli, but a little higher for Klebsiella and Proteus. And what's interesting here is that clinical resolution at 28 days was 70% and 58%. So for fosfomycin was pretty low, even though it's in the guidelines, and microbiologic resolution to nitrofurantoin was 74% and 63% for E. coli. So these are rates that are lower than the rates in the studies that were used to make the guidelines. And the question are, should we make adjustments in our guidelines? There are problems with this study. There are a lot of loss to follow-up. It was open label. Positive cultures were not required at baseline, since a lot of European countries especially give treatment with the recommendation is not to get baseline cultures. And the response rate was still lower than other studies for both arms. So this is simple cystitis, but obviously in the hospital, most of your patients who are admitted with UTI or for UTI do not have simple cystitis, although I would tell you simple cystitis and asymptomatic bacteriuria are probably as common in hospitalized patients as is admission for UTI. So a lot of patients are admitted with UTI, so which is why I thought I'd include that case. But this is a more complicated UTI syndrome. So this is a 48-year-old woman. She has multiple sclerosis on ocrelizumab, B-cell depleting agent, similar to rituximab. If you are not familiar with it, she has neurogenic bladder and uses intermittent catheterization in order to empty her bladder. She has a history of recurrent UTI. She has a childhood allergy to amoxicillin with a rash, and she's admitted for meropenem therapy for MDR E. coli cystitis. So her symptoms are malaise, dysuria, bladder spasm, leg spasm, low back discomfort. These are, in people with neurogenic bladder, you won't have the frequency urgency, especially if they catheterize, but they often have painful catheterization and other symptoms of infection. But no flank pain, no nausea, no systemic toxicity or not fever, so we'd assume it's still a bladder infection without fever. And she has more than 182 white cells and nitrates in the urine, and she's growing ESBL producing E. coli, which is susceptible to amoxiclav, piptazo, meropenem, and imipenem, but resistant to trim sulfa, fluoroquinolones, and aminoglycosides. And the question to you is, which of the following is correct? There may be more than one. Will oral fosfomycin be adequate for her syndrome? Will oral nitrofurantoin be adequate for her syndrome? We don't have susceptibilities, but say we can add it on. Would amoxiclav be adequate if only we could make that allergy go away? Or do we really need to only give her IV carbapenem and keep her in the hospital or some kind of form of IV therapy from the home or in the home? Or can we do all of the above? So let's first define her syndrome, because that will help us make the decision. And in this syndrome, I would call it afebrile. She's catheter associated, although she's drained and doesn't have an indwelling catheter. Cystitis with an MDR organism in a patient with abnormal bladder function. But it's still a cystitis, and it's still without toxicity. So this is a patient that you would probably treat in the outpatient setting had she not had this MDR that required a carbapenem. So here we are admitting her because she has a resistant organism. And the true answer for this is actually all of the above will be appropriate because we're treating cystitis. So if we could test or just try oral fosfomycin, oral nitrofurantoin, they would be appropriate because we're still treating cystitis. Amoxiclav is appropriate as well. It's acceptable. Doesn't always work for ESBL, but depending on the MIC, we can look at it and help you. It would work. And as we know, you have a talk about this, so I'm not getting into it with a slide. All these rashes from childhood to amoxicillin, most of them do not represent a real amoxicillin reaction, and there are many protocols now to introduce amoxicillin to these patients. I know you have a separate talk about that. So yes, one daily IV erdapenem, not rather than meropenem, probably would treat this, but may not be necessary. This patient can get away with oral therapy. And this is an interesting study about hospitalizations for UTI. So if you look at this study, it looks like a hospitalization for UTI from 98 to 2011 in the national surveillance system. And UTI hospitalization increased over time. We'll talk a little bit about the seasonal peaking in summer. But the severity is decreasing. So as you can see in the lower slide, hospitalization in the bottom for pyelonephritis did not change, but hospitalization for UTI did increase. These are, and as you can see, that's true for men and women, though more so for women. And the reason why is resistance. People are admitted for IV therapy because they have no oral options, not because they meet criteria for hospitalization otherwise. And this variability, is UTI a seasonal disease? Obviously, it's not seasonal like influenza, but apparent that just to me, and I'm saying this by insinuation, this probably reflects how important hydration is in the prevention and of urinary tract infection, even though only a few studies showed it as an effective intervention. There are studies who have. And I think we all have the experience that people with UTI experience more of them. But let's talk about MDR resistance. So we now define, on our health streams, it's a question. MDR is resistant to more than one antibiotic class or one antibiotic class that's important in the treatment of an organism. And it's important to recognize risk factors for MDR because that will determine what do you do empirically for patients and whether you choose empiric therapy or get cultures in deciding how to treat patients. So the predictors of MDR are having had MDR before, a recent stay at a healthcare facility, and that includes LTACs or a hospital, and travel to areas with high rate of resistance. Remember case one, the patient that flew and had a PE? It would be important to know where she flew. This patient actually flew to India, and her, UTI was with a highly resistant E. coli. But travel to areas with high rate of resistance, and this may include Southeast Asia, Israel, Mexico, within Europe, Spain. So ID can help you with that. Of course, you can get a culture too. And we know that rates of both healthcare and community-associated MDR are on the rise. We used to think of ESBL as a hospital-associated infection. In the last 20 years, it's not been necessarily the case. But remember that many, at least E. coli, retain susceptibility to fosfomycin and nitrofurantoin. So things to know about resistance, and I know you have a talk about antibiotics and resistance. I also didn't include my slides on the SBL and AMC and all of that because I know Dr. Johnson will be talking about that. But not all resistance is actually acquired resistance or MDR. Some of it is an intrinsic factor of the bacteria. For example, all these bacteria on this list have natural resistance to ampicillin. So this is all intrinsic factors. If you see Proteus vulgaris, it's going to be resistant to all these antibiotics here, including nitrofurantoin, including cefazolin. So we can see the bug and already kind of know what would not be effective. It might still work because we know in UTI, in simple cystitis, we make clear bacteriuria with a drug that looks resistant, but I wouldn't choose to use it. But the most important factor is to know your hospital antibiogram. Ours is published for any clinician to see. And this is our general hospital biogram, and this is our ICU biogram. So for example, if I see a patient in our ICU with Enterobacter sepsis, urosepsis, I know in my hospital I need to use cefepime. Or maybe amikacin would work. But in my hospital, cefepime is nearly as good as meropenem for this particular organism. And for some other organisms, I can see, so I wouldn't use piptazo for this. But if it were Klebsiella, piptazo would be pretty effective, actually more effective than cefepime. So knowing your antibiogram locally will help you choose an antibiotic. If someone has a serious or not even so serious, this can include urinary isolates up in the all isolates, choose an empiric antibiotic based on, if you don't have the culture results yet. So if we have an MDR and we think we can use an oral agent, what are our options? So if the patient is able, you have to make sure the patient is able to take oral medicines. You have to make sure there is an effective oral option for their syndrome. So if they have cystitis, that's easy. But if they have pyelonephritis, you're not going to use nitrofurantoin. We'll talk about that. And if you have bacteremia, you're not going to use doxycycline. We never use doxycycline for bacteremia. Orals are great for step down. If someone improves from bacteremia or pyelo, you can switch to oral. But again, they have to be appropriate for the syndrome or source control completely achieved. So if someone comes with pyelo with bacteremia, you're not going to simplify it to nitrofurantoin. Obviously, the allergies, make sure they're real allergies. So many times they're in the way of our treating patients, and we can make them go away with the help of the allergy service if they are not real. And we talked about tetracyclines for UTI. They're cleared mostly through the hepatic system and stool, and they're not good for bacteremia. So if you're going to use a tetracycline as your only option, I would strongly suggest calling ID to make sure it's appropriate. So let's talk about some of the oral agents. Nitrofurantoin is one. It has one indication of febrile cystitis, and the dose is the macrobid, the macrocrystal, 100 milligrams BID. It's very broad for UTI, but there's no tissue concentration. You get no level in the prostate, none in the kidney. The GFR restriction in the PDR is 60, which is problematic considering our population with UTI. And that's why the American Geriatric Society, and the reference is below for you to use, has changed their criteria to more liberal creatinine clearance threshold in the elderly to 30, as long as it's a short course. So if you have someone with 30 to 60 GFR and you want to use nitrofurantoin for a short course for UTI, you have the support of the American Geriatric Society to do so. But there are also side effects that are more in the elderly. The common are nausea, headache, less common but serious, hepatitis and neuropathy, and of course the idiosyncratic interstitial lung disease. Fosfomycin is an old revived drug because of resistance. It's FDA approved, and you can get lab testing for E. coli and E. faecalis and Enterococcus faecalis for the indication is uncomplicated cystitis. Other organisms may be susceptible. Some argue it's overestimated, but in some European study, 90% of enterococci, some staph as well, and other enterobacteria, other bowel organisms like Klebsiella. Personally, I have less success with Klebsiella and maybe even Pseudomonas when you have no other option and you feel it's safe to try it. If it's a simple cystitis and you're okay if it doesn't work for a day or two. Response rates for 3 grams in the old study, 78 to 83%, although the one I showed you was 58%. And for complicated cystitis, that is cystitis you want to treat for longer. You could repeat the dose every day, every 2 days, every 3 days for the duration that you want to treat it. The issue is cost and approval, but you can give more than one dose if you feel one dose is not long enough for your patient. We'll talk about durations later. Fluoroquinolones are excellent to treat UTI that is not resistant, although resistance is on the rise in some countries, 40-50%. We generally, from the gram negatives, we like Cipro. The notable advantages of bioavailability, tissue penetration, prostate abscesses, kidney, even bacteremia. The oral bioavailability is great. It's inexpensive. It's a shorter oral cost. So why don't we have it as first line? Because then we'll never have it again. But also because of stewardship. But also because of all the connective tissue damage and black box warning, and the fact that we really want to reserve levofloxacin for respiratory infections and other complicated infections, and that's why we don't want to overuse quinolones for things that can be treated with something else. And they're also big drivers of C. diff, MRSA, and there is the drug interaction with the positive ions. So you get a patient and they are known to have MDR in the past, and they have a UTI or even urosepsis, and you want to choose an empiric regimen. Should you use their prior culture? And the answer is, before we look at that, is yes. But this is one of many studies from Israel, which is a country with a lot of resistance issues. And this is about 20,000 cultures from about 4,500 inpatients with previous resistant urine isolates. Resistant rates were very high. Cipro, almost 50%, ESBL, 32%, CRE, carbapenem, resistant Enterobacteriaceae like Klebsiella and E. coli, 1.7, and non-fermenters like, Enterobacter or Pseudomonas, 2.6%. And a previous culture was very predictive of a repeat resistant organism, at least within 2 years, with some decline of the carbapenem resistance, but not the others. And you can see it here on the right. So the answer is prior resistant isolates will persist and should be used to guide antibiotic choice while culture is pending. So we talked about the woman who had simple cystitis with a very MDR E. coli and decided we could have treated her with an oral regimen and not admit her for carbapenem. But what about this guy? He's a 75-year-old man. He has the exact same organism, but a different story. He has recurrent E. coli UTI. He keeps getting them with the same organism. And as soon as we stop, it come back, stop, come back, stop, come back. And he's admitted because an ID consultant decided he has chronic prostatitis and now he needs an antibiotic that penetrates the prostate. So he's brought in to get a PICC line and start a very long course of carbapenem for this, IV meropenem, and he has the same exact results. So I'm not going to read this to you. And the question is, which one of these options that I gave you before would work for him? So let's talk about UTI in men. So let's start with cystitis. So that used to be under complicated UTI, and typically the recommendations used to be to treat 14 days. But nowadays, when we try to emphasize stewardship and use shorter regimens, do we really need 14 days? So there is one large study that was done at the VA, and there is a multi-center study now enrolling. But this study looked at 272 men randomized within 7 days of starting either Cipro or Bactrim to stop at 7 or continue for 14 days. And the bottom line of this, so I don't spend too much time on that, is no difference in response rate or recurrence rate between 7 and 14 days for afebrile cystitis. The flip side of this is a somewhat problematic French trial that looked at febrile UTI, same number of men, only fluoroquinolones used, and treatment success with febrile UTI was much better for the 14-day group. The study was actually stopped early for that reason. The question is, did these men really have cystitis, or do they have a syndrome that needs longer than 7 days, prostatitis, pylorus, a complicated infection? So I think still for simple afebrile cystitis in a man, 7 days is probably adequate. Do we know that about things that don't penetrate the prostate, nitrofurantoin or other? We don't have data on whether antimicrobial penetrating the prostate are preferred for simple cystitis. But I would say if you can't use Bactrim or Cipro, you can use fosfomycin or nitrofurantoin. It possibly will work. You don't always need to penetrate the prostate in a man. So acute prostatitis and chronic prostatitis. Acute prostatitis is easier. I call it the pyelonephritis of the prostate. People have systemic toxicity, they have pain, they have fever, but the symptoms are in the prostate. They're not in the kidney. Acute prostatitis requires treatment, probably for 2 weeks with a drug that penetrates the prostate. Chronic prostatitis is kind of so hard to diagnose. There are no good criteria, but we suspect it when someone has an UTI with the exact same organism over and over and over again, relapsing every time you stop antibiotic. And then we want to treat for chronic prostatic infection and colonization. And the treatment duration is long. And what antibiotic do you use? One that penetrates the prostate. So it's lipid soluble, alkaline, and the standard is trimethoprim sulfa or fluoroquinolones. Doxycycline or azithro actually have very good tissue penetration, but beta-lactams penetrate less well. And there is a recent study in Greece where fosfomycin is not as costly as here, and they used fosfomycin every 1 to 2 days at the 3-gram dose for 6 to 12 weeks. They got a lot of diarrhea, but they had very good response for men with susceptible chronic prostatitis using oral fosfomycin, and we sometimes do it if we can get it covered. So for the men with the same bug but different syndrome, oral fosfomycin probably okay if you can pull it off in the US. Nitrofurantoin is not adequate. Amoxiclav is meh because of not great and penetration. You can try it before you put IV if you have no other option, but it may or may not work. And obviously IV therapy with a carbapenem would work. Is all recurrent UTI or relapsing UTI in a man prostatitis, obviously not in a woman? No. So why do people fail? There's persistent in the bladder epithelium that's been shown, and this is an electronic microscopic proof that E. coli penetrates the bladder wall and can persist there longer. And the way to treat this, longer therapy with tissue penetrating agent, not nitrofurantoin. Failure to eradicate vaginal carriage, so you keep reinfecting. Unsuspected upper tract infection, structural abnormality, resistance reinfection, or the symptoms are not due to cystitis. I have so many women who are chronically colonized, who are older, who have dysuria, but when you ask more, this is not dysuria. This is vaginal atrophy with chronic burning, not just with urination. You treat that with vaginal estrogen. So let's move to another patient. And this is very recent. So this is a 59-year-old female with stress incontinence. She has a normal post-void residual, so she empties. She has several prior episodes of cystitis, all with E. coli. And because it's not an outpatient talk, I'm not going to talk to you about intervention to prevent recurrent UTIs, but I included them here as a clue to this, to what we do. So she's chronically on methenamine, vitamin C, vaginal estrogen, cranberry, and D-mannose for UTI prevention. That has helped her a lot, but she still gets recurrent episodes about every 3 months or so. And the last one was 7 days ago. It was treated with nitrofurantoin. It was 3 months ago. And I was treated with 7 days of nitrofurantoin. She never had pyelo or urosepsis, no recent travel or hospitalizations. I put all of this here because these are the questions I ask them. Were you in a place with resistance? No recent antibiotic except for UTI, no history of kidney stones. So she gets just recurrent UTI, and her previous organism always a very susceptible E. coli. So now she's admitted from the ER for 2 days of acute onset fever, chills, progressive right greater than left flank pain. She has a fever, heart rate of 102. She's not hypertensive or just soft blood pressures that respond to fluid. She has a positive UA. You give her fluid and APAP, and she feels better, and her heart rate is down. So we would say she probably has pyelo, but not septic or not septic shock. And she has allergies to penicillin, ceftriaxone, and trimethoprim sulfa that are real. I put them here. They're really anaphylactoid reactions. Her UA has more than 182 cells, also has white blood cell clamps, a few red cells, has bacteria, and trace squamous cells. So question one, which is a tricky question, is does this woman need imaging? Emergency rooms typically image these patients, and neurologists would too. And the question is, does a simple pyelonephritis episode need imaging? And the reason, and the answer is, if you think she has obstruction, you image. She has some red cells. It can be just from UTI. She was imaged. And as you can see, she has bilateral pyelonephritis, this hypoattenuating lesion in both kidneys. But she has, I take my word for it, she has some punctate stones, but she doesn't have any obstructive stone. She has no obstruction. Obstructive pyelonephritis is a surgical emergency, or these days IR emergency, but you call urology or you call IR for PCN or both. This is her prior isolate. It's very susceptible. And question number one is, what are you going to give her? Fosfomycin, fluoroquinolone, aztreonam. Remember, she is allergic to ceftriaxone, AMP, and Bactrim, erdapenem, or amikacin 1 dose. And I will tell you 2 to 6, except 4, she had an anaphylactoid reaction. I don't see a reason to desensitize her. You have all these other options. 1 is not appropriate for pyelonephritis, but all of these are appropriate. The question is which has the most stewardship. She has febrile pyelonephritis with no obstruction, no shock, no MDR risk, and multiple antibiotic allergies. So think what you would do, and then I'll tell you what we have done. So what are empiric antibiotics for febrile or hospitalized UTI? And those will come up in the new guidelines, maybe slightly different than my suggestions here. The most important is use what you know about the patient and also what you know about your local and hospital susceptibilities. She comes from home, so the hospital may be less relevant, but the hospital represents what's in your community, maybe slightly sicker, slightly more resistant. A patient without sepsis, shock, or resistance risk, you can go relatively narrow as long as you're not worried they'll progress rapidly. So typically we would give ceftriaxone to this patient, but she is allergic. So you can give fluoroquinolones, piptazo. You can consider amsulbactam or trim sulfa if you know it was she had or an organism that's susceptible. If you know it's a Pseudomonas or suspect, then you have to give us anti-pseudomonal, and we usually use cefepime or ceftaz. Piptazo you would use if you know a previous one was susceptible, but it's less predictable. If someone known to have an MDRO or ESBL producer, your best, most reliable carbapenem drug is a carbapenem. Piptazo may work, but there are controversial studies. Some studies showing equivalence, some studies say carbapenem is better. I did not show them for the sake of time. And I would say if someone is looking shocky or really septic, I would definitely go with a carbapenem to save their life, and also use meropenem because erdapenem has a different PK/PD. You spend less time in the good MIC in a drug that's every 24 hours. Once you de-escalate, you can go to erdapenem. If you worry about MC, use carbapenem or sometimes cefepime. If they have severe beta-lactam allergy, you can always use aztreonam. She could actually use, she met criteria for quinolone, so we didn't go with the aztreonam. And of course, gram-positives, I gave you some options here. And if you have someone who's really septic, who has a lot of resistance and a lot of allergies, that's when you call us in ID and let us kind of think about what to do. So this woman has very susceptible E. coli before. She didn't look that sick, so we felt, well, be steroids, and we gave her a quinolone, and then she improved, and it was an IV quinolone because she couldn't take orals initially, and then she changed to oral Cipro, and the question is, how long would you treat her? So uncomplicated pyelo. The data support 5 to 7 days if you use fluoroquinolones, or 7 days for some other antibiotics, and they're as good as longer. So you don't need to use a long course unless you have some complications such as foreign body obstruction, severe sepsis, etc. They're slow to respond, they're pregnant. Otherwise, someone like her would do just fine with 7 days of Cipro. And if it's febrile without bacteremia or pyelo, I probably use the same criteria as a pyelo. So this patient gets oral Cipro, and then she's ready for discharge. But right before discharge, her blood cultures turn positive for E. coli, no ESBL. Do you go back to IV? You stop Cipro and go to ertapenem or aztreonam, making sure she's not resistant? That's her admission cultures. Stop Cipro oral and give IV because she has bacteremia. Continue oral Cipro and send her home, but give her 14 days. Continue Cipro, send her home, and give her 7 days. We actually did number 4. So I'm going to show you here very briefly. There are evolving studies looking at 7 versus 10 to 14 days of antibiotics for simple bacteremia with gram-negative rods, not just UTI. The 3 major studies are shown here, and this is a meta-analysis. This is the reference up here that looked at these 3 studies, and all 3 showed that for patients who are hemodynamically stable, who resolved their fever 48 hours prior to their end date of antibiotic, and they had Enterobacterialis bacteremia, that's E. coli, Klebsiella, etc. So they had similar outcomes with 7 versus 14 days. So short courses of 7 days likely adequate when source control achieved, and there are no complicated factors, but there are some patients you need to go longer for. I would also say that once they're controlled, if you have adequate oral regimen, you can step down, as we discussed before, and this approach emphasizes stewardship. I'm going to quickly move to 2 other topics I want to cover for you. One is, this is kind of a board review question. These are different scenarios. Pregnant woman, first prenatal visit, diabetic woman, poorly controlled, quadriplegic man with a catheter in an LTAC that has cloudy urine and leg spasms, pre-op evaluation for TURP, a person with bilateral hip replacement who's getting a cystoscopy, and a patient with stones, recurrent urosepsis, who's getting a stent exchange. All of them don't have symptoms of UTI at the moment, but someone sent a UAN culture, and they have 50 white cells and greater than 100,000 Cipro-resistant E. coli. Who would you treat for this asymptomatic bacteriuria? And the answer is you would treat the pregnant woman, the pre-op eval for TURP, and the stones with a nephrostomy exchange, but none of the others. So what is asymptomatic bacteriuria? This is from Nature Medicine or Nature Urology, actually. These are bacteria. They come from the rectum or in women, the vagina, climb up the urethra and swim in the bladder. That's asymptomatic bacteriuria. Once they invade the urothelium and cause inflammation, they typically cause cystitis. So asymptomatic bacteriuria is this phase. And it's in a person without symptoms of UTI. And we recommend screening and treatment in patients who are pregnant and in patients with urologic procedures where mucosal injury is expected. Note, not for joint arthroplasty. Patients with bacteriuria have more joint infections after arthroplasty, but they would not have it with the E. coli that's in the urine. They would have it with the staph that's on their skin. So asymptomatic bacteriuria is just a marker for a patient more at risk for getting an infection, but doesn't need to be treated. And similarly for cardiac surgery, it's not indicated. In our hospital, we got away with it. I'd like to remind you that the indications for treating asymptomatic bacteriuria are narrow, and even if a urine was sent, you don't need to treat it. Even if it's a Pseudomonas, even if it's ESBL, even if it's a scary bug, if it's not symptomatic and there's no indication, don't treat. What about Candida in the urine? We see it all the time in the hospital, and most commonly it's catheter-associated or vaginal contamination, and it adheres really well to plastics and to epithelium, so it's kind of stuck between the catheter and the epithelium. And it's promoted by E. coli and Klebsiella and definitely by antibiotics. And the majority don't need treatment. You remove the catheter, you put a new catheter, the biofilm on the urethra is still there, so you may find it again. But you treat it only if you worry about upper infection, if you worry about fungemia, or if you really have UTI symptoms and no other explanation. And then you would use fluconazole. But you can also use echinocandin and liposomal amphotericin. One quick reminder, not all yeast in Candida. We have several cases in the hospital that they saw yeast in the urine. The patient went sent home, and then the yeast turned out to be Cryptococcus. Those are the people you bring back to make sure they don't have systemic cryptococcosis. And as a prelude, talking about catheter-associated UTI in general, catheters are irritating. They cause pyuria, and they're a highway for bacteria, so they cause bacteriuria. So we don't treat pyuria and bacteriuria unless we're convinced they're associated with a clinical syndrome. And since you bypass the dysuria and you are not going to get urgency and frequency, you have to treat systemic symptoms. So we treat them a little bit later, but we're only going to treat symptomatic ones. In patients with chronic catheters, always think of prostatitis because they have a biofilm that builds, and please focus on prevention. The best way to prevent catheter-associated UTI is when it's feasible to prevent a catheter. If you're treating a catheter-associated UTI, replace the catheter. That's not true for stents, but replace the catheter about midway through therapy. When do you get consults? I would say that most cases of UTI, whether it's urosepsis, pyelo, cystitis, prostatitis, don't need a referral or a consultation for urology or urogynecology. The yield is low. Most times your urologist, you probably know it already, will say nothing to do. See us in clinic if there is something. What you can use as a quick thing is a bladder scan to make sure someone doesn't have retention underlying, because that's something you can do at the bedside, either with a bladder scan or with a straight cath. However, ID can help with outpatient prevention, inpatient and outpatient antibiotic stewardship, step down. So call us when you're struggling with antibiotics. And urology obviously can help if you need source control, obstruction, relieving obstruction. Obstructed UTI is a medical and surgical emergency, and then to coordinate outpatient evaluation. Similarly, imaging in UTI. It's difficult to make a unified recommendation. There is definitely excess imaging in UTI in emergency rooms and the hospital. And you should think of what is the clinical question you're asking the image, the radiologist. Is there you get urgent imaging if you worry about obstruction, lack of source control in a febrile or septic patient. You get non-urgent imaging if you worry there is an underlying functional or anatomical or surgical or IR correctable abnormality, or if there is a delayed or inadequate response to treatment that should work. If it's resistant, change the antibiotic. If you choose imaging, the usual imaging of choice is a CT of the abdomen and pelvis. If you're just looking for stones, not in the setting of infection, you don't necessarily need contrast. You use contrast if you worry about abscess. Some cases, like pregnant women, you might use an ultrasound. And I put here a list of things that may make you think that you need a CT if you don't think they're obstructed. If they have hematuria, pelvic floor dysfunction, prior surgery, etc. And here are some guidelines from radiologic societies. And I put here just for fun, or my fun, I don't know if that's your fun, some things you might find on imaging if you get them for the right indication. This is a patient who did not respond to therapy for pyelo and developed a large perinephric abscess. This is a patient who had an obstructive staghorn stone, picked up on the KUB and then on the CT. And this is a patient with chronic xanthogranulomatous pyelonephritis as an explanation. This is basically a mesh of crystals infected with bacteria that cause granulomatous inflammation in the kidney as a cause of recurrent UTIs. So my takeaways for today: a negative urinalysis is excellent negative predictive value for clinically significant UTI. Community and hospital drug resistance are on the rise, so know your community and hospital data. Some complicated, including bacteremic UTI, can get only 7-day courses, but if the patient has to be improved, you have source control and no complications, and have an adequate regimen for his syndrome, and then can get a step down to oral. Indication to treat asymptomatic bacteriuria, very narrow. Please don't overtreat it. For a recurrent UTI, I didn't talk about that except insinuated it. We prioritize non-antibiotic interventions. They're all in that women's case. And you can use ID to help with that in the outpatient setting, not necessarily inpatient. And imaging and urology consultation should be guided by clinical suspicion for a treatable finding or need for source control intervention. And of course, ID is always happy to help with evaluation and management. If you haven't seen that clip, he said we should have taken antibiotics to treat more seriously. This is Dr. Glaucoma Flecken, and that's his very recent skit on ID rounds. I think you'll find it very relevant to your practice. And thank you.